Hello, and welcome to the Great Lakes Neurotechnologies webinar series. My name is Holly, and I will be your moderator for this session. Today's webinar is Parkinson's Gait, Global Efficacy of DBS in Pharma Therapy. If you have any questions during the session, please type them in the question box on your screen. I will compile the questions and ask them to the presenter at the end of the presentation. With that, I'd like to introduce Dr. Elizabeth Brokaw, Senior Biomedical Researcher, who will be presenting today.
All right, hello everyone. I'm Elizabeth Brokaw, and I will be talking to you today about quantifying Parkinson's-related gait impairment and how these measures can be used to improve the global efficacy of deep brain stimulation and pharmacological therapies. Oh, there we go. Sorry about that. Slides weren't changing. So anyway, in this talk, I'm going to be talking to you about the importance of measuring gait impairments due to Parkinson's, the importance of quantifying these impairments and how this could be beneficial for research and clinical care. And then results from a study that we did using the kinesia sensors to quantify these impairments both in discrete and continuous tasks. All right, so Parkinson's disease results in a wide range of symptoms, including impaired balance, slowed movement, tremor, rigidity, and cognitive impairments. All of these can negatively affect an individual's gait, which makes gait a good global measure of an individual's impairment. So for example, in this video, there we go. In this video, you see an individual who has slowed movement, he has tremor, rigidity, short strides. Entering into this turn, you can see marked flex posture and freezing of gait. And also some instability as he kind of sways to the side. And all of these negatively affect this individual's mobility. And mobility is exceedingly important for quality of life. Individuals with reduced walking speed have reduced community integration. And individuals with Parkinson's disease have increased fall risk. In one study, over the course of a year, 68.3% of individuals with Parkinson's disease reported that they had fallen at least once. So there are medications like levodopa that are effective at alleviating symptoms, but they require repeated dose adjustments due to the chronic and degenerative nature of Parkinson's disease. Deep brain stimulation offers a treatment option for individuals whose symptoms can no longer be controlled by medication, and it affects symptoms like tremor very quickly. However, there's a lagging effect on gait that can be up to 3 hours, which makes it very difficult to tune deep brain stimulation for gait-related outcomes. So in general, individuals use symptoms like tremor, and there's a lost potential in tuning deep brain stimulation. So commonly used outcome measures for research and treatment adjustments are subjective and low resolution. For example, the Unified Parkinson's Disease Rating Scale asks clinicians to rate an individual's impairment on an integer scale from 0 to 4. And for example, you can see in the guidelines for assessing gait, the clinician is asked to differentiate between a, quote, minor and a substantial gait impairment, which does not provide specific information about the type of impairment and has large potential for variation. So moving forward, there are two types of tasks that we would like to evaluate. They're discrete tasks. These are highly sensitive, short evaluations. These are standardized tasks like finger tapping. So we want to evaluate an individual's impairment in these standardized tasks. But additionally, there's continuous evaluation where you can get a measure of all day how an individual's impairment affects their everyday activities. They're a global measure of impairment. And this is a lower burden on and interferes less with an individual's daily activities than doing multiple discrete evaluations. So looking at quantifying impairment with the kinesia sensors, what we did was we put the sensors on the individual's thighs, the back of their feet, and their sternum. And 42 individuals with Parkinson's disease completed this protocol. 19 of these were evaluated both with deep brain stimulation on and immediately after deep brain stimulation was turned off. The individuals completed tasks from the Unified Parkinson's Disease Rating Scale, and these included toe tapping and leg lifts, where the individual was asked to complete the movement with the largest range of motion as quickly as possible in rapid succession. The Arise task, where the individual is asked to stand from a straight back chair. The Gait task, where the individual is asked to walk and turn, and freezing of gait is also evaluated during that task. The Posture task, where the individual is just asked to stand as tall and straight as possible. And Postural stability, where the individual's ability to recover from a clinician-applied force is evaluated. So all of these tasks were videotaped, and they were scored by 3 clinicians, and their average score was compared to kinematic measures that were gained from the kinesia sensors at the same time. So looking at these kinematic measures that we obtained, we saw good correlation between the kinematic measures and the clinician measured scores for all but one of the tasks. So for example, down here in freezing of gait, an individual with a larger amount of impairment, a 4 on the clinician scale, spent more time in the turning. So it took longer for them to turn because of freezing. Same thing seen in postural stability. Individuals who are more impaired take more steps in recovering for that clinician-applied force. In the gait task, individuals who are more impaired have a lower swing angle, so shorter strides. Getting up from a chair, 0 crossings is changes in directions in the person's sternum, so rocking back and forth to try and build momentum. So the more times people are rocking back and forth correlates well with increased impairment. Leg agility, same thing again. You have a reduced angular velocity when there's more impairment. And same thing in toe tapping, reduced angle when individuals have more impairment. So these show that we're able to get some clinically relevant measures from these kinematic sensors. So the one task that did not show good correlation was posture. And posture is evaluated based on many characteristics. For example, these 2 individuals from our study both received average scores on the UPDRS of 3. However, they present very differently. So for example, the individual on the left, they were both asked to stand as tall as straight as possible. However, you still see marked flexion through her hip and knee. And the individual on the right has a slightly retropulsive posture and a large amount of neck flexion angle. And due to the positions of the sensors, one on the sternum and the others on the lower extremity, we're not able to pick up neck flexion angle. So looking more specifically at the deep brain stimulation effect, how this changed individuals' impairment as measured by the kinematics and the UPDRS scores. So those 19 individuals who were measured both with deep brain stimulation on and off were evaluated, and this was done immediately after deep brain stimulation was off. So the full effects of deep brain stimulation on gait have not necessarily manifested. But the kinematic features still showed significant increase in impairment when deep brain stimulation was off for 3 of the tasks: toe tapping, leg lifts, and gait. And these also showed significant changes from the UPDRS scores. So while the results from the use of the kinesia sensors for gait evaluation were positive, a simplified one-sensor system is desirable for easier use in the clinic and potential home use by individuals with Parkinson's disease. Additionally, we want to convert this information into a form that is clinically relevant so it can be easily integrated into clinical practice. So for example, we have a kinematic measure of toe angle amplitude. We want to convert that into a UPDRS equivalent score for toe tapping. So this was done using a model. A model was created to predict the UPDRS scores from the kinematic features. And this model showed good correlation with clinician scores. So as you can see from these figures on your right, the toe tapping task had a good correlation between the model predicted scores and the clinician scores, same with leg agility, gait, and freezing of gait. And this shows that a single sensor is sufficient to provide information about many of the UPDRS tasks. So moving forward, this model works well integrating into the Kinesia HomeView system. So the Kinesia HomeView has been validated in several clinical studies for its ability to provide quantitative, clinically meaningful information about tremor, bradykinesia, and dyskinesias. The system comes in two components. There's the patient kit, which goes home with the patient, which includes the sensor and the tablet. And the tablet assists individuals running through the different discrete tasks, and then collects that data from the sensor and transmits it to the servers via 3G, and where it is processed and then uploaded onto the web interface for the clinicians to view, so they can get a general idea of the individual's impairment throughout the day for a wide variety of tasks. So this has many applications for telemedicine, individuals who are too far to have repeated visits, for medication dose adjustments and things like that, for deep brain stimulation programming, especially for Gait, because as I said, there's that long delay in how long it takes for the deep brain stimulation to fully affect Gait-related outcomes. So if quantifying these impairments could be done at home, you could get a better idea of how to tune the deep brain stimulation. And for clinical trials. So for example, this is an outcome sheet from the Kinesia HomeView. And you can see an individual here has a lot of impairment in postural, in these tremor measures, where red shows more impairment and green shows reduced impairment or no impairment. And you can see a color map scale of this individual's impairment throughout the day. But additionally, you can see the effects of changing medication. So in this example, increase the medication and you see a marked reduction in the individual's tremor throughout the day. However, at the same time, there's also an increase in dyskinesias. And all of this information could be incredibly helpful for clinical studies. So in summary, we've shown that discrete evaluation is possible even with a single sensor. We can get good measures of an individual's impairment. But we also want to get that continuous throughout the day. How is an individual's impairment affecting their everyday life? So to get this general activity level and just general function with a low time burden, so unlike discrete tasks doing these throughout the day, they just go about their general life and it's just a single sensor. And we can use a single sensor on the thigh to classify an individual's activities in between sitting, standing, and walking. So from the acceleration due to gravity, when the individual is sitting, the sensor is in a certain orientation and we can detect that. And when the individual comes to standing, we can detect this new orientation to determine when the individual is standing. Additionally, we can look at the angular velocity from the sensors and tell when the individual is walking. We can also tell when the individual is sitting and moving or standing and moving, which includes walking. So to validate this continuous process for evaluation, we look specifically at discrete task data where we know what the individual is doing. So we looked at those individuals from that last study, the 42 individuals, 19 of whom did both deep brain stimulation on and off, and specifically examined the Gait and the Arise tasks because they are the most analogous for activities of daily living. So looking at a single sensor in the Arise task for the individual going from sitting to standing, and the Gait task where the individual was asked to walk and turn, we classified the data into 4 categories: whether the individual is standing and moving, which includes walking and some postural sway; standing still, person is settled and standing still; sitting and moving, like scooting in the chair; and sitting still. So from these specific tasks, we saw the expected classifications. So in this task, the individual is asked to walk and turn, and we saw that the individual spent most of the time standing and moving because they're walking. However, there was some time spent standing and not moving where the individual was in the turns. And we also showed that the time that the individual spent standing correlated well with the UPDRS freezing of gait and gait scores. So as you can see from this figure, individuals who were more impaired spent more time standing and not moving, getting kind of frozen in those turns. So the ARISE task also showed expected classifications. The individual spent time sitting and not moving, then transitioned to some sitting and moving, then standing and moving before they settled into standing and not moving. And once again, this task time showed good correlation with the UPDRS scores, so individuals who were more impaired took a longer time to complete the ARISE task. And this data suggests that even with these basic classifications, we can provide useful information about an individual's impairment level. So looking at the changes from deep brain stimulation, so these are the 19 individuals who were tested both with deep brain stimulation on and then immediately after deep brain stimulation was off. So again, the full effects of deep brain stimulation on gait had not fully been recognized. And the UPDRS score for the change in the ARISE task was not statistically significant. However, looking at the classification changes and the changes in the clinical measures showed good correlation. So for example, the change in the amount of task time from the individuals having deep brain stimulation on and off correlated well with the change in the clinician score. And the same thing was seen between the sitting time and the clinician score. And this suggests that even somewhat small changes in impairment might be detectable with this basic continuous evaluation. So the ARISE task also showed significant increase in the time the individual spent sitting and moving with deep brain stimulation off. And this goes back to that discrete task where you saw the individual rocking back and forth, or we talked about the individual rocking back and forth. And that is exactly what was seen here in the classification method. So the individual rocking back and forth to try and build up momentum to come to standing. And you can see the change in classification here with the individual sitting and moving before they come to standing and settle into standing. So here's another example of a subject who, with deep brain stimulation on, rose to standing very quickly and settled into standing still very quickly. However, as soon as deep brain stimulation was turned off, you have a longer time before the individual starts moving, rocking back and forth, and then the individual comes to standing and moving, but takes longer, again, to settle into standing. And this continuous information can be used in a clinical trial through evaluating an individual's activities throughout the day. So across this example 4-week intervention, you can see how the activity level throughout the day, but you can compile this into week by week and then get a general summary of the individual's activity level and how it's changed over the course of the intervention. So in this example, the individual is spending less time sitting after the intervention and more time walking. And this suggests improved mobility, which could result in improved overall health. So in conclusions, we know that gait impairment negatively affects quality of life, and improving evaluation through quantifying the information and getting an individual's changes throughout the day, we could improve outcomes from an individual's medication as well as research outcomes into the effects of different treatments. We show that these kinesia motion sensors were able to collect and quantify some clinically meaningful information about gait, both in the discrete tasks and the continuous tasks. So we have an ongoing study to further validate these models and to evaluate the time-based effects of deep brain stimulation being off over the course of 3 hours. So this is being done in coordination with the University of Cincinnati and the University Hospitals at Case Western. So at this point, I'd like to acknowledge the rest of the research team at Great Lakes Neurotechnologies and our collaborators at the University Hospitals at Case Western and the University of Cincinnati. All right, and I'll open up for questions.
And as a reminder, if you have any questions, please type them in the questions box on your screen. And our first question is, can you describe again what you mean by discrete versus continuous monitoring?
Yes, so let me go back to that slide. So for discrete tasks, they are predefined tasks that the individual completes. So things like finger tapping or toe taps, those other tasks that you saw, whereas the continuous monitoring is really about what the individual is doing throughout the day, getting without them having to do predefined tasks that are a high burden on the individual.
Our second question is, I would like to know how the system is defining the turn, start, and completion.
So that is based on the angle of the sternum and how the individual goes through the turn. There's more information about that actually in the paper, which is listed at the bottom of the page here. It goes into more detail about how that angle is used to determine when the individual is entering into the turn. So the paper is listed right here.
Our third question is, can we have access to the raw data using your system?
Yes. So if you are using kinesia sensors, you will be able to get raw data from these sensors about the accelerations and the angular velocities.
Our next question is, you indicated that Gait takes a while to respond to DBS. However, you have significant changes noted in your quick on-off assessments. How is that possible?
So the deep brain stimulation affects some symptoms very quickly. Like I mentioned, tremor is affected quickly by deep brain stimulation. However, some impairments take longer. And to get the full measure of how Gait is impaired, there have been studies showing that it can take up to 3 hours to get the full effects on Gait.
Our next question is, do you have any publications on Gait assessment that we can review?
Yes. So as I mentioned, these are on the slides, which will be available for you. And the publication, one publication is listed here at the bottom of this page, and then also the one about modeling, the models that were created, is shown here on this slide and describes how the models were created.
And our next question is, so how do you explain immediate effects of DBS on Gait in the presentation?
So, as I said, it affects many symptoms differently over time, and the effects were in kind of speed-related and other, having some trouble finding it, but the effects that we see, again, the whole measure of impairment can take a long time, but some subsets of the impairment can take less time to be mitigated. Yeah, so you can still see changes even though you could see larger changes over time, I guess is what I was trying to get to.
And it looks like those are all the questions we have time for. If we weren't able to get to your question, we'll have a representative contact you directly. Thank you for joining us today.